3-year initiative to expand the quantity and quality of New York State mobile crisis response. And technical assistance is provided to support the achievements of these objectives. The objectives being 24/7 mobile crisis response services for adult, children, and youth available in every county, to significantly increase billing and reimbursement for mobile crisis services, and to coordinate within the overall state crisis response system. And our next slide. So Chris Copeland is going to talk to us about the CCSI consulting services.
Yeah, good morning. Chris Copeland, I'm a Senior Director of Consulting at CCSI. These webinars that we're providing, the 5 webinars, are just part of the technical assistance that CCSI is going to be providing in partnership with OMH. We're going to be looking to providing over the next 2 to 3 years technical assistance, both individually and in maybe cohorts, as we look to see where your needs are. I'd ask you, everybody, to complete the survey that we sent out. We've so far had 36 completed surveys. We thank you very much for those. Anybody that's not completed theirs yet, we'd appreciate those surveys being completed, because they give us a really good idea as to what the needs are of each of your agencies. If you could go to the next slide. So this just gives you an overview of the services, the consulting services that CCSI provide. We're going to be focusing, obviously, over the next over this project with billing, how to bill, best practices around increasing Medicaid and increasing the quality and the quantity of crisis services. But just to know that we are a broad multi-service consulting agency, and we'll be bringing all our resources to bear on this particular project. And particularly just like to introduce, if you go to the next slide, both Amy Jackson and Tricia Williams, who are working with me on these slides and will be presenting today around billing. This is the second part of the billing webinars, and I would like to turn it now over to them for the content. And thank you for joining again.
Thanks, Chris. So today we're together to participate in part 2 of billing for crisis services, and we'll take a look at claiming fee-for-service Medicaid and Medicaid managed care plans, a little bit of information about electronic claiming, timely filing and appeals, developing a process for billing, and documentation for best practices. Just a note before today's meeting, we did send the slides out ahead of time for note-taking as requested in our last part 1 presentation. Also, the Q&A, all the questions that came through have been added to that companion guide that also went out in the appendix section. So, you know, when you have a chance after our meeting today, perhaps, or sometime in the upcoming days, if you want to take a look back at those questions that came through and the responses, those are available in that companion guide. And today we're starting with claiming fee-for-service Medicaid. And just a note before we even get started, I just would like to highlight that the propensity of your claims, the majority of your claims are going to be through Medicaid managed care. They won't necessarily be directly through fee-for-service Medicaid. That would be a much smaller population. You might recall from part 1 that services for children can be submitted to fee-for-service Medicaid, and under the CPEP program, there may be instances, but those are those occurrences where the member is eligible for Medicaid and is not enrolled in a Medicaid managed care plan. So just to take a look at the notes here on our slide, claiming fee-for-service Medicaid can occur for community mobile crisis services for children in the case when the child is provided mobile crisis response or follow-up and is enrolled directly in New York State Medicaid as opposed to Medicaid managed care. Also for CPEP providers, just as I was saying, though in that case for both adult or children who are provided mobile crisis response services, or follow-up, and also enrolled directly in Medicaid, not enrolled in Medicaid managed care. Adult mobile crisis response and follow-up services are eligible for Medicaid managed care billing only. So there is not a fee-for-service Medicaid component available to adult mobile crisis response services, except in the case of CPAP. So just a note, just a step back to that slide, just wanted to point out that the timely filing for new claims for fee-for-service Medicaid is regulated. It is 90 days. Claims for payment, they must be initially submitted within 90 days of the date of service. And we encourage you again to please take advantage of eMedMe's training, which is available for free through emedme.com. So when it comes to claiming our Medicaid managed care plans, the first thing you want to think about is who are these plans servicing your counties? And you can identify the Medicaid managed care plans that are available in the counties that you service through this link that's provided here, also in our resources page, and verify that you're contracted for mobile crisis service. You might be contracted with the carriers that you see, with the Medicaid managed care plans that you see servicing your counties. But also you might want to understand if mobile crisis is a component that's been included in your contract, or is your contract limited to certain services that does not include mobile crisis. Timely filing for Medicaid managed care plans is not regulated. So that can vary from plan to plan. Some plans will follow Medicaid, the 90-day. Some will expand that even greater to 180 days. And I've even seen instances where it's 365 days. So when you're thinking about filing your claims, just bear in mind that your filing limits in order for a claim to be eligible for reimbursement has to be received timely, and it can change from plan to plan. Reimbursement, so the payment back to the service providers, is regulated for all insurances in New York State under our prompt pay laws. So for electronic claims, reimbursement must occur within 30 days of receipt of a clean claim. And when we say clean claim, that's kind of an industry term, and that really refers to claims that are appropriately and completely coded. So they're coded correctly and completely. And for clean paper claims, insurance plans must reimburse within 45 days of receipt of a clean claim. If they exceed those timeframes, Medicaid managed care plans are required to pay interest to the provider when these timeframes have been exceeded. Just as a side note, best practices, I would encourage everyone in the audience to plan to submit claims within 30 days of providing the service. So you really want to get that revenue cycle started, and we'll talk in greater depth about revenue cycle management in our upcoming webinar, which I believe is March 9th. And we'll see that schedule very specifically at the end of the presentation. So Medicaid does require coordination of benefits. And this was one of the questions that came through in our session 1. So I really wanted to break this down for the audience so that we have an understanding. So as a standard, Medicaid is always the payer of last resort, always and forever. So the first thing that you might think about doing is checking with the recipient or family members or support services if that person is eligible for Medicaid. Are they also insured by any other third-party coverage? So that could be Medicare or commercial insurance, for example. Claims submitted to Medicaid with zero fill, which is a way of coding the claim to indicate that it's been sent to another insurance, but perhaps that was a zero payment. If it's coded with zero fill, the providers have to retain evidence on file that the claims were initially billed to Medicare or third-party insurance and were also denied before seeking reimbursement from Medicaid. So if that's something that you or your billing companions and colleagues are doing with a zero fill coding, then just keep in mind that you need evidence that the claim was actually denied by Medicare or other third party. The exception is when services are statutorily not covered by the Medicare program. In those instances, providers may bill Medicaid directly without first receiving denials. There is MLN Matters guidance in CMS that indicates services that are not covered, but that is from 2020. I, standing before you today, am not confident that I could locate statutory documentation that mobile crisis services are not covered by the Medicare program. That's real in-depth research, and we certainly can look into that further. But without having that evidence of statutoral non-coverage, then the recommendation is that providers would bill Medicare first, and then once the claim is adjudicated and a denied service, sending that claim on, in particular for fee-for-service Medicaid. As a side note, I would also encourage you to work directly with your Medicaid managed care plans. They may have their system set up knowing ahead of time that Medicare does not cover a benefit. So if you have a recipient that's eligible for both Medicare and Medicaid, they may already have programming in place to account for that. So that can vary from plan to plan. And for members who are dually eligible, people who are eligible for both Medicare and Medicaid and covered under a single managed Medicaid plan, there's no need to submit the claims twice. That plan should be taking care of both the Medicare portion and the Medicaid portion. And we'll be able to review this in depth further during office hours if this is a topic that people would like to come back to with us. Next slide. So some questions did pop up regarding coding, and we just wanted to make a point of identifying for you where your coding guidance should be coming from. There is cost associated with these resources, but these are the official and consummate sources of information for codes that are entered onto a claim. So the AMA is the CPT code set. The 2022 has been released. It includes the descriptors and including modifiers and coding guidelines. They're all encompassed either in hardcover, softcover, or electronic format. And the same is true for the UB04 claim form. The official UB04 Data Specifications Manual 2022, which is copyrighted by the American Hospital Association, is the only official source of UB04 billing information. Also, multiple formats are available, including electronic and softcover. So we wanted to make it a point to make everyone in the audience aware that these should be your resources for your coding. Next slide. A few notes about electronic claims filing. The claim submission methods that are available, you can submit through software under your practice management systems and hospital information systems. The software is used for scheduling, registration, billing, and account receivable management. Claim files can easily be created. They can either be batched or sent individually to plans under electronic submission. You can submit claims directly from your PMS or HIS system, or you can upload those claims to another source, for example, Clearinghouse, which we'll look at in a second. There's also a direct data entry option often available through your Medicaid managed care plans. It's usually used by smaller practices or for low volume claims. Direct data entry solutions are ideal for organizations that don't have a robust PMS or HIS system, but they want to submit their claims electronically, which is a recommended best practice. They allow you to key the information directly into an online claim form and submit the claim electronically. And then finally, we have our clearinghouse, which is an intermediary. So the clearinghouse accepts the claims from a PMS or an HIS system, or from online resources that you're working through directly with the clearinghouse, and they will batch those claims and forward them on out to the insurance payers. They function as an intermediary, and they provide certain services that really remove some administrative burden. So they submit reports to you showing the claims that were submitted, claims that were accepted. There's all sorts of electronic tracing happening, and you can have reports of that. So the claim that's submitted, that's tracked. The claim is acknowledged as being sent to the insurance plan by that insurance plan, that's traced. And then there's another level of reporting where it will actually report back out that the claim was actually accepted for processing. Clearinghouses will also ensure that codes are not missing and other key information that should be on claims in order for claims to meet HIPAA requirements and coding requirements. Each Medicaid managed care plan will work with you directly to provide you with their electronic claims identification number and their guidance for filing claims to their plan electronically. So this brings us into timely filing and appeals. So we've touched on the claims, new claims. If you recall from a few slides back, Medicaid, fee-for-service Medicaid is regulated with a 90-day time window to submit new claims. And managed Medicaid plans are not regulated. Often they will follow that 90-day time frame and can go typically beyond that. It's important to know and truly strictly adhere to each Medicaid managed care plan's filing limits for both new claims and appeals. The Medicaid managed care plans, they will identify their timely filing timeframes for new claims, for corrected claims, and appeals in their provider manuals. And provider manuals are very easily located within the managed Medicaid plans websites. It's usually identified within the content of the contract between the Medicaid managed care plan and a provider. And as a best practice, recommended again to develop a standard to file all claims to all plans to meet the minimum standard of at least 90 days. And again, I would stress that you might want to even consider 30 days from the time that a service is provided to getting the bill out the door to the payer. Next slide. So more about appeals and requests for reconsiderations. And I use those two terms because some plans will make a distinction between what an appeal is and what a request for reconsideration. Oftentimes, a request for reconsideration is in a case where maybe the plan has made an error. You've taken a look at all the information and you feel that the way the claim has been processed is not correct. And so you'll say, hey, we'd like you to reconsider this. Or perhaps there's more information that you have about that claim. An appeal is often when something has been missed, a time frame has been missed, some other essential information might not have been included that needs to be added, and you've exceeded the normal time frame. So you would want to make a distinction between an appeal and a request for reconsideration, but they're essentially the same. You're asking the plan to take another look at the claim and process it again. What I would recommend is that you create a record of each Medicaid managed care plans that you're working with, those that are available in the counties that you service, a record of their standard timely filing periods for filing appeals and requests for reconsideration. Understand if you have variances spelled out in your contract. Sometimes contracts might have a provision that says, yeah, the standard of the plan is to file within 180 days if I need to have a claim looked at again. However, we've worked on our contract and we've gotten it out to 365 days. I would add a cautionary note about that. If your contract does vary from the plan, under best practices, if your filing terms in your contract are greater than that plan standards, I would strongly recommend following the plan standards. When you get outside of the regular standard programming that's happening to process all of the claims that are coming in by the thousands to each Medicaid managed care plan, you're really opening opportunity for claim delay, could be human error. The more the system is able to just receive and process the claim within its own programming without human intervention, the less errors that do occur. And also touching back on that revenue cycle management. So if you need claims to be re-looked at, reprocessed, you don't really want to delay that and keep pushing that out, because now you've got that revenue that might be due to you that's sitting out there. And we'll, again, look at that more closely in our upcoming webinar.
Amy, I just wanted to also pause and remind folks, so as we're looking at our claim came back, there's something wrong, we want to make those appeals or those reconsiderations, I want to point everybody to their CARC codes. So when we get our information back to us, we get coding that tells us what potentially was wrong with our claim, and making sure that we're going back to those CARC codes and understanding what the managed care organization was communicating to us. I think sometimes we miss that whole piece and that whole component. And again, that's part of revenue cycle management, and that's part of the process. But it's really important when we're doing our appeals and our requests for consideration to make sure that we understand what was actually going on with that claim.
Excellent. That's a great point, Trish. We can move to the next slide. So again, following our conversation thread, and we're spending some time on this today because, you know, when I introduced myself, I may have mentioned that I spent many, many years working for both commercial and Medicaid managed care health insurance, and specifically with the provider community. So these are some pitfalls to avoid, I guess I would classify these under, and really save yourself some time and maximize that revenue that's due to you. So best practice, the first thing I would do before reaching out to the insurance plan is check the coding that was sent out on the original claim. This is such a key and essential piece, because in that action, you may discover, before having to pick up the phone to spend any extra time talking through with someone, you might discover, oh, I used a rate code with no modifiers, or a rate code for a patient whose age is not within that rate code category. So you might find coding errors that exist on the claim that can just be adjusted. There's a mechanism for voiding and resubmitting the next claim. So if it's coded correctly, then you would submit the appeal to the Medicaid managed care plan according to their plan appeal process. If it's coded incorrectly, you can file that adjusted claim, and that would void the original and replace it with a correct version of that claim. Under best practices, I do recommend filing appeals in writing, even if you have spoken on the phone, you've called the plan to initiate the appeal. I highly recommend following up with it in writing. And again, you might be hearing a theme threaded through here. Do not delay. File any request for your reconsiderations and appeals within the plan's timeframe requirements. The request will be denied if timeframes are exceeded most frequently. Next slide. And then an additional note here, working with Medicaid managed care plans under best practices, and I can't stress this enough, do not delay submitting new claims in order to avoid denials. And that may seem like a crazy sentence that's written there, but it happens very frequently. So for example, you're working with your Medicaid managed care plan and you realize they have an existing programming error. You've been on the phone with them. You're saying you're denying my claims inappropriately. I think we even had a Q&A last session where there was back and forth because the plan was interpreting reimbursement differently under APG, for example, instead of direct rate for, CPT rate. So in those instances where you may be aware of a recurring error, either denial or payment error, do not hold your claims waiting for the plan to correct their programming. During this time, continue to file all claims timely, all appeals and all claims. Even if you're aware that the claims might be denied in error, they have to be received timely. And the whole point of that is once the plan corrects their programming, then they will have your claims on file to adjust them. If you're holding those claims back because you happen to know they're having a problem, there's nothing to adjust once they get that fixed. And then before you realize that they've fixed the issue and 3 or 4 months have gone by before you've made that realization that, oh, gee, I haven't talked to my representative or my claims department at that Medicaid managed care plan in a couple of months. I wonder how that issue is coming along. Well, now you're outside of timely filing. So you have a whole nother issue to resolve. Now you're back into that appeal process. So I can't stress it enough. Please submit claims, even if you are knowledgeable of errors that are occurring on the plan side. Next. And so now we're going to move into developing a process for billing and working, more to come on working with Medicaid managed care. So I'm going to hand this portion over to Trish and look forward to any questions that might be coming through.
Thanks. And I figure let's also take a beat. Let's see if there are any questions. I've been checking the chat throughout, but I wanted to also invite folks if there are any questions. We're willing to kind of take them right now. And I'm going to move my chat so I can control the screen. And so let's take a deep breath, right? We have gone through the last 2 sessions. It's a lot of information. And so now we want to wrap all of that up, and we want to summarize and figure out, so where does all of this stuff we've been talking about fit in, and how do we create a reasonable and successful billing process? So let's first look at kind of what are our billing practices, and all of this should look very familiar as revenue cycle management, right? So we register the patient, we confirm their financial responsibilities. So we look at our MEVS, Medicaid Eligible Verification System. So that's something like an e-TASES, where we're checking and making sure. We're going to prepare those claims. We're going to check for compliance. We're going to transmit the claim, monitor that adjudication, and then follow up on that patient payment and handling of collection. So really, we're going to get the money and figure out how we're going to make sure we keep the money, right? So that's really what this process is going to be all about, is getting the money and keeping the money. We want to talk about how do we prepare with our discussion and with our contracting with the Medicaid managed care plan. So there's a couple of different things. We're going to see different acronyms and different titles for the Medicaid managed care plans, right? So we have MMCP, which is Medicaid Managed Care Plan. We have MMCO, which is Medicaid Managed Care Organization. We have MMC, which is Medicaid Managed Care. And we use all of these words interchangeably. So making sure that we even understand our acronyms are really important, because we are surrounded by acronyms in the system that we work within. We want to make sure that when we're looking at our contracting, that this is all about making sure we have the Medicaid managed care patients that are enrolled in the plan that we're contracted with. And so we know that we're billing that appropriately. The operations and financial changes that happen as we contract with Medicaid managed care plans is we have to now start to capture insurance information. We have to really hone in on what our billing processes are, and we have to be able to monitor that patient eligibility for all of the follow-up activities. So this is what starts to change as we look at contracting with Medicaid managed care. So what's the function and the purpose really of the MCOs? So the characteristics of it is all about keeping the medical costs down, and it's all about preventative medicine, patient education, and addressing the social determinants of health. Payments to providers for services rendered. So this is the mechanism of how we actually receive our payment. So those are really the high level functions of what the managed care organization is there for. And then we also look at what are the expectations. So what are they expecting from us as the service provider? Well, it's all about that reduction of unnecessary services, right? So it's all about that prevention. How do we make sure that we are using the highest level of care necessary, and that we're not going over the necessary care, and that we're really coordinating that patient care between all of the service providers around, and that we are always about being the solution to the problem for our patients and for the clients that we work with. So let's talk about those preparation activities. And we talked about this actually in session 1. So this is where we start to build that foundation, and we start to think about, what did we talk about in session 1? Well, we want to make sure that we're Medicaid approved, that we're approved obviously through the crisis program, that we have our NPI numbers all set, that we actually understand Medicaid and managed care component billing for our crisis services. So we call that the Medicaid and managed care billing primer, right? We want to incorporate those codes into our billing system. We want to do some testing with our electronic medical record. We want to have communication with them to make sure that everything works well. And I've always suggested that as you're ramping up and beginning a new service with a managed care organization, that you actually do some testing with the claims to see how things get pushed forward, how they get received, and being able to see if there's anything that has to be done prior to going live. And that's really important to make sure that you don't have those hiccups. Nobody wants to start already having to do an appeals process right at the very beginning. So really doing that testing and working with your managed care organization is so, so important. So we also then want to understand the cost of our services, right? So before we get into any kind of a contracting situation, we want to understand what is the cost of our services. And that's actually something that David Wozniak will be doing in session 4 when we start to highlight how do we really understand expenses and costs that are part of our programs. So components to the actual contracting, and you'll see over to the left, the contracts include different expectations. So we have the management of the episodes, we have care coordination and discharge planning, and then I can't drive it home enough, as Amy talked about, that timely billing and how do we make sure that we've responded to the appeals process. So the very first component that we will notice in our NCO contracting is really about management of the episode. So we want to make sure that we understand where our process begins and how we're going to be doing insurance verification. How do we make sure that we're doing ongoing insurance verification to ensure that the person is eligible for those services with the managed care organization? Again, that helps with making sure a seamless billing process. Are we going to be standardizing any forms, especially if we have to work with multiple managed care organizations? We have to consider who is going to be responsible for that insurance verification. How does that work when it comes to who is within our organization? What questions will we be asking the identified payer? How is our business office going to be working with our front end office and working with the folks and our clinicians that are actually billing for the services? And then are we contracted with the MCO for that service recipient? And if we're not, then what's our process, right? So we may be contracting for MCO services in other areas and other service lines. So we may hear the word single case agreement. We don't have to do that in this particular program, but again, being aware if we have contracts for other service lines and service provisions, we know that they use all kinds of different jargon that is very different to what we're accustomed to. So let's look about care coordination and discharge planning. So this is really about how do we start to manage those services, right? So monitoring the contract terms and our rates, and we know that we have our set rates. And rates are something that David will be discussing as he goes over the budget when it comes to expenses and revenue. We want to make sure that we're monitoring and documenting and communicating as the patient or the client condition begins to change, whether it's stabilized or whether we have to get an alternative approach to how we're going to help that person, right? We're going to capture any exclusionary information so that we are going to mitigate any potential losses on the front end before we even get into that billing process. We know that crisis services have so much coordination of care and making sure that we're pulling everybody together to get that person the services and the supports that they need. And then we also have that managing services of utilization management. And again, I reflect back on our first session where we talked about utilization management in the traditional sense for crisis services. We would never be doing a look back. We would never be doing that right now. But it is all about the medical necessity and that we have all of our things in a row. We have all of the things that we need to make sure that we are demonstrating the medical necessity of the service. And then that last component is all about that timely billing and making sure that we've talked to our Medicaid managed care provider and also whether it's our electronic medical record that's doing the billing for us or whether it's a clearinghouse or whatever that is, that we have all of our clear lines identified as to how we're going to actually bill and communicate to get the money, right? So the lines of business identified, what needs to be billed, how we're going to be using CPT and HCPCS codes, and really how our contract does all the definitions for it. And all of that should be really simple and laid out because we have all of our guidance documents that help drive that conversation. And then when we're doing our billing, whether we're talking about whether it's the e-billing and the portal, we're doing drop billing, and all of these are different components and different types of ways that we can bill, whether it's through our clearinghouse, whether it's through our electronic medical record. And then the different procedures, because unfortunately, all of the different managed care providers may have their own way and their own processes that we have to take into consideration, which just makes this a little bit more complicated and requires us to do some management to make sure that we understand, right? So as Amy discussed, timely can look different depending on each managed care organization. So wanting to make sure that we have identified what is going to be our standards and how do we make sure that we meet the standards of our contract. I think it's really important as well that we set the stage for both our business office and our operational staff. And we make sure that we have training and we have all of the supports that we need so folks clearly understand really how they're supposed to communicate, how they actually bill, any cheat sheets, any protocols. You know, when we look at a risk cheat sheet, it's all about what are those potential risks. So when we go to our front office and we look at how are we going to make sure that we register this patient and we get their insurance information, what that looks like, it's going to look really different for crisis services. So making sure that we have that procedure and that plan put in place so that we can respond to all of those needs. And again, just to continue along those lines of timely billing. So we would have, you know, our business office systems where we would make sure that we're addressing the discharges. So what is the timeline, any EOB reviews, how are our posting processes, adjustments, overpayments, and that aging review, right? How old is that claim? Any red flags with the language. So the reason why we put this in here is crisis services has a lot of different nuances to it that are different from when we are billing and contracting for other service lines and other service provisions. So we really want to make sure that we're paying attention to those submission timelines, timely filing. As Amy said, you know, if we're looking at something that looks outside of what is the general practice, and we've looked for exceptions in our contract, that does expose us and put it at different risks. Look at any risk terminology, look at any access to take back and what does that look like. And we want to just make sure that we poke holes and we ask questions, right, when we're doing our contracting. And in our first session, something that Amy had brought up and I think is just so important is to look at the provider manual for the managed care organization. Usually you don't even have to be a signed up provider. You can go to their websites and you can simply read them. Not the most exciting reads, but I'll tell you, they at least help you understand what are the expectations and what do you have the wiggle room for. I think the biggest thing that we want to drive home is when we have our processes in place, when we pay attention to how we're going to get the insurance information, how we're going to continue to monitor it, how we pull together all of those billing codes that we talked about in session 1, and then how do we actually do the process of billing that helps us ensure that things are billed on a timely manner, we get the money on a timely trajectory so that we can pay for all of our bills and all of our expenses. We have addressed the potential of loss of revenue. We know that we will not have significant costs that incurred without that reimbursement. We don't have an overstatement of our revenue. We really are tackling any adjustments that could potentially be coming. And then we don't have those cost out failures. So again, it's just really important, and these processes are really part of that revenue cycle management, which we will be going over in additional sessions with Dave Eckert and David Wozniak. So that leads us really to the end of this particular session. Our upcoming session on March 9th in 2 weeks will be the client engagement session, and you'll notice that's from 11 to 12:30. Let's see, our next slide talks about really what are we going to talk about during that session, which is we're going to talk about person-centeredness, trauma-informed engagement practices, what's essential to identifying the needs and enhancing that motivation and linkages to services, and then the tools and technologies and practices that we can have at our disposal to gather that critical information for that billing and the insurance. So all of that stuff that we just talked about, with making sure that we understand what folks have as their insurance and how we move that forward. So I want to take a minute just to kind of pause and give some opportunity for any questions. I saw that there was some exchanges going on in the chat. Let's see, and it looks like Amy, you've answered a lot of them. Is there anything, Amy, that you want to bring forward that maybe the rest of the group may want to hear? Anything that you want to point out?
Yeah, I do. There's a really great question came through about members who might not be enrolled in Medicaid at the point of that initial contact, and then sometimes even work through the organizations that are providing the mobile crisis services. That's one of the connections that they help them make. So they might get them connected to Medicaid. And the question really is, can we bill for those crisis services if they become enrolled in Medicaid? And the answer is yes. When Medicaid issues eligibility, enrolls that member retroactively, at least to the point of covering the dates of service. As long as the dates of service are included in that enrollment effective date, then the answer is yes, you can bill. And then that brings us back into this conversation that we've been having throughout regarding timely filing. The question I think really is there in that scenario, is there a regulatory time frame for submitting claims once retroactive enrollment has been made? And I don't know the answer to that off the top of my head. However, I do know that the managed Medicaid plans are required to be able to accept the claims. However, it might put you back into that appeal process only because, again, we're back into that standard programming. So if the member's not enrolled, you might have a claim, but you don't have a plan to send it to. You connect the member to Medicaid, they select a managed Medicaid plan. Now you know, okay, yes, I have this claim, and now I know the member has selected United Healthcare or Fidelis or whomever, and now I need to get this claim over to that plan. If your timely filing has been exceeded, then you might need to have that communication. But nonetheless, as soon as you know what that plan is, you immediately want to drop that claim to that plan. So this is a great illustration of exactly what we're trying to impress today. As soon as you're aware and able to send that claim, you want to get that out the door and into the plan, even if it'll deny because they'll say, oh, you've exceeded this member's timely filing. That creates the claim in their system. Now that claim is assigned a claim number, and now you have something to be talking about. I would like this claim to be reconsidered because enrollment was actually issued retroactively back to the date of service, and that enrollment wasn't issued until 4 months after the application. Things do happen, so we need to have this claim reconsidered. And as a secondary note to that, I will do some research, and we will email back out to the group if there's a specific time frame for managed Medicaid plans to accept claims for retroactive enrollment. So, and then we do have a couple of people in the audience who, this again, as we mentioned at the top, we issued a set of the slides from today in notes form so people could take their notes as requested. And we also included a guidance companion. There's some people in the audience that don't have that email. So we'll make sure that everyone that was present today gets the emails that were sent out this morning. Yep. And so Janet Sleva is asking, can we access the webinar from February 9th? So Janet, if you could just give us a little bit more, do you mean right now while we're together, or do you want us to resend that out? We do have time today.
Yeah,
There-
no, I was just wondering if we could have access to kind of review, because I missed that one. So it's
Oh,
like I'm
sure.
in part 2, so I missed part 1, so I'm kind of just need a little more information. So if there's access to the webinar where I can watch it another time, that would be great.
There is
Absolutely.
access. Yeah, so we actually sent the links, but we are also working on a learning management system so that everything will be pulled all together and folks can access all of the information. So in the meantime, it's through email, but we're evolving as we move through this process.
Great, thank you.
Now, and I do believe that those did go out, but we will absolutely be able to send those again. That's never a problem. Now, Corey Anthony Chisholm is asking, is the retrospective for 30 days or more? And I'm Corey, again, I think we're talking about this retroactive enrollment. And so when you say retrospective, can you just tell me a little bit more about what you mean by that? Or do you mean just new claims in general?
Sorry about that. It's correct. It's supposed to be about the retroactive. So I think that the way I understand how Medicaid works, because you do become eligible, and I think you kind of answered it. You know, if we do service a client and then they become, qualify for Medicaid, and it was last month that we serviced that client. The question here is, with this retroactive, are we able to bill for the last month's services, or we're not? That's kind of what I'm trying to figure out.
Yes, absolutely. So the timely filing limit for claims submission is 90 days from the date of service for fee-for-service Medicaid. So for example, you serviced them last month, they went through the process, they were the individual was approved by Medicaid retroactively to cover that date of service, then you're still, I mean, if it's a system, you're still within that, you know, and if it's an instance where it's going to fee-for-service Medicaid, you're still within that 90-day window. So there's really nothing more that needs to be done other than getting the bill out the door. You might run into an instance where, and I would say, generally speaking, you need to know each individual Medicaid managed care's timely filing limits as well. Although I would be surprised if they're less than 90 days. They can typically go longer than, but very often I can't imagine them cutting the standard fee-for-service Medicaid, but you gotta work directly with your plans. They are the owners of their rules. And there's not a way we could encompass every plan's timely filing limit. We wouldn't want to, because as soon as something is put in writing, you know, it tends to change. But in any case, working with your Medicaid managed care plan, understanding their timely filing, again, the same thing would apply. If you're within that window of their timely filing window, 90 days, 180 days, great. You just, you know, once that eligibility comes into play, you're still within timely filing, you get the claim out the door. If it's taken a while for that eligibility to be updated in the Medicaid system, then you would work with your plan. So you would still get the claim out as soon as you know what plan they've enrolled in, which Medicaid managed care plan that individual has selected for their enrollment. You would still drop the claim to that plan immediately, whether you know it's outside of timely filing or not. You want to get the claim out, because that action of getting the claim is what then creates a record in their claim system to be appealed or reconsidered. So then that opens the door. So, okay, I know I've gone, you know, this plan's filing limit is 90 days. I know it took 6 months for Medicaid to get this individual enrolled, but, and these cases do come up, but nonetheless, they've enrolled them and it's retroactive and covers my date of service. I still want to send my claim. The claim will go out. It might deny for exceeding timely filing, because again, we're working with standard programming that's happening. I don't want to be, certainly don't want to underestimate or insult anyone in the audience, but I often describe it as really the computer's brain. The claims processing system is really how the computer is thinking about each claim. And there's all sorts of standard programming that's going into it. So the standardized programming, so it may not, you know, the computer knows timely filing is 90 days, and the computer knows that the date of service is more than 90 days from the day it received the claim. It may not be, the computer's logic and programming is not necessarily always going to be sophisticated enough to say, oh, but this was a person who got a retroactive enrollment. That's a lot of logic to be building into a claims processing system. So that opens the door. Once the claim is received, it's assigned a claim number, and then it can be worked with. And then you have something to either that managed Medicaid plan or fee-for-service Medney, or submitting your request for it to be reconsidered in writing. And oftentimes, the other thing I would just add about submitting requests for reconsideration, any documentation to support what you're asking. I would be concise and simple with what you're asking. Here's the claim denied for late filing. However, members' enrollment was retroactive. Here's their enrollment letter from Medicaid. You might have a copy of that, or here's an image of the MEVS enrollment system showing the transaction date, something of that nature. So you're really letting the plan know what went wrong and how to fix it. Really, I wouldn't leave it up to those operators who are looking at all sorts of appeals. Again, hundreds and hundreds by the day, if not thousands coming in. So yeah, Corey, making this a very long answer, the retrospective is not necessarily limited. It really depends on the plan's timely filing and also when that enrollment took effect. So there's an effective date, and also when did the transaction happen in the Medicaid enrollment system. So you still can work with that plan from the effective date as long as it's covering your dates of service.
Amy, can I just add? So with all that, we also have to make sure that we have a billing process that is going to capture all of the necessary information. So when that person does become eligible for fee-for-service Medicaid or Medicaid managed care, that all of that information is already collected in the manner through the process that the organization has. So you can't wait to collect all of the information on the intervention until the person is eligible. You have to already have a process in place that is allowing you to be collecting all of that information right at the start. So that goes back to what was the insurance verification, what is the information that you're collecting, so that as soon as you're ready, you are billing and pushing all of those claims forward. So I can't tell you enough how important it is to have a solid revenue cycle management process put in place, and that you have a solid process as to how you collect all of the components and all of the information to be able to push that claim forward. So Corey, I hope we answered your question.
Yes, thank you.
Yeah, and that, Corey, just as a side note, a couple of people had asked about that same scenario. So I'm glad that question came up. And thanks for adding on to that, Trish.
Sure. I'm looking to see if there's any other questions.
There's not. We'll take a look at the registration list from today, and anyone that didn't receive this morning's email with our companion guidance and you know, the notes format for slides, we will resend. We'll make sure that everybody gets that. And there's a lot of requests for that February 9th. So we'll be certain to resend, and that will include both the slides and the recording. The recording is available as well as the slides. And then, as Trish had mentioned, we're in the process of developing a platform to be putting all of these materials for everyone to access. That's in the works. There's more to come on that. I hope I'm not giving away secrets, but in any case, we'll be able to make these materials available in email as well as hopefully as a standalone access.
So just as a reminder, we have our webinar calendar up. So on the 9th, which is 2 weeks from now, we're going to do that client engagement conversation, which we talked about earlier. It's going to just be that person-centered, trauma-informed engagement practices. How do we really identify and enhance and motivate a client to get to services? How do we gather all of that crucial and critical information so that we can get the money and keep the money, right? So we can bill the insurance, and we can make sure that we keep all of the funds that we get. On the 23rd, 2 weeks after that, we'll do that introduction to the financial modeling, and that's with David Wozniak. And that's going to be that overview and the demonstration of the fiscal modeling tool. We'll really take a look at what are the important components that are going to inform that model, and then just putting that fiscal model into practice. And then our last session, just for this component of the series. So remember, Denise mentioned this is a 3-year journey that we're going to take together as we continue to form our services moving forward with Medicaid managed care. We're going to do measuring and sustaining success, and that's where we're really going to talk about that revenue cycle management. We'll start to think about the data and reporting structures that we want to do as we do delivery of service, and also those critical quality measures, right? So we talked about in the middle of this session, what are some of those expectations that managed care organizations have, and what is their responsibility? And part of that is making sure that our customers are satisfied, that we are utilizing preventative practices to keep folks healthy. And so we're going to look at what are those quality measures when it comes to client satisfaction, the reduction of unnecessary services, and then that timeliness of service. So that's what we have coming up. I did move through slides. We do have some resources to help folks with just really kind of, processing all of the information, not only that we talked about today, but in our very first session. So you'll notice we have some of the provider manuals, we have some of the Medicaid coordination benefits guidance, and just additional documentation to help everyone be able to work with Medicaid managed care organizations. I am going to check the chat one last time to see if there's anything else. Understand if you have to jump off to another call. I think we're closing our call. Is there any parting words you would like to offer, Amy?
I'm glad to be able to offer everyone a half an hour of their day back. This went smoothly. There was lots of questions. I would just restate the Q&As that came through from our last session are included in the companion guide that we sent, and just to assure everyone on the call that we'll be happy to resend any of the materials that are necessary.
And remember, we